This video will demonstrate the technique and workflow for minimally invasive hematoma evacuation with the Penumbra Artemis system using Axiom navigation. There are multiple workflows that can be used, but the advantages of using Axiom navigation will be highlighted in this video. The patient is a 82-year-old female with a history of hypertension. She was out to lunch and developed acute onset of left-sided hemiplegia. Premorbid modified Rankin score was 0, and initial ICH score was 3. Initial CT scan showed a large right basal ganglia hemorrhage with approximately 65 ml volume. This is the initial non-contrast CT of the head, showing a large basal ganglia bleed with interventricular extension, significant mass effect on the right hemisphere. Patient was taken 6 hours later to the hybrid OR for a cerebral angiogram to rule out cerebrovascular malformation, and while on the table, an expert CT is performed to confirm no expansion of the hematoma. That CT can be used for stereotactic planning. This is the expert CT that is performed on the angiography table, showing stability of the hematoma. This scan can be used for stereotactic planning. After confirming that no vascular abnormality is present, the patient is repositioned for the Artemis procedure. A right posterior parietal entry point is chosen. The Axiom system allows for navigation without rigid head fixation, and we use the non-invasive patient tracker placed on the patient's forehead. This is the initial trajectory down the first axis and second axis, respectively. Probe's eye view then shows that there is a safe trajectory. 3D model shows the entry point and trajectory. After confirming the entry point and trajectory, the patient is prepped and draped. 3.5 centimeter incision is made and a burr hole is placed. The dura is cauterized, and a 19 French peel away sheath is then passed into the hematoma, ending approximately 2/3 to 3/4 of the way along the long axis. The EM stylet can be placed inside the lotoscope to allow real-time tracking of the endoscope during the procedure. The second side port can then be used for continuous irrigation, and the Artemis can be passed down the center tract for the evacuation. These are intraoperative pictures showing the navigation of the sheath into the hematoma. Once the sheath is navigated to the correct position, it's removed. These are now intraoperative videos. When we initially go down, basically all you're able to see is blood. Continuous irrigation helps with clearing any blood products. At that point, the Artemis device is brought down and initial hematoma is evacuated. Once the far portion of the hematoma is evacuated, some white matter can be seen. The sheath is then pulled back and more hematoma comes into view. Artemis device is then brought back in to further remove that hematoma. Copious amounts of irrigation are necessary for this procedure in order to continuously clear the products. Eventually, after the hematoma is significantly evacuated, we can start seeing white matter around the cavity. Any areas of bleeding are then identified. It is often unnecessary to cauterize bleeders. They can simply be treated with irrigation and patience. This is the setup showing the endoscope on the left and the stereotactic navigation on the right. Once the hematoma is fully evacuated, we can navigate the endoscope around and make sure that we are not missing any areas that could potentially have more hematoma present. And once you see white matter all around, and typically the procedure is completed at that point. This is the final view of the cavity after resection and thorough irrigation. No active bleeding. There is no large chunks of hematoma present, and we're able to visualize white matter around the entire cavity. There are some air bubbles present, which will resolve over time. It is important to thoroughly inspect the cavity to ensure there are no actively bleeding vessels, as this could potentially lead to postoperative hemorrhage. This is the significant amount of hematoma evacuated, and the incision, which is quite small. An intraoperative CT scan is performed, which shows no hemorrhage and good evacuation of the hematoma. Postoperative CT scan also shows excellent hematoma evacuation, resolution of midline shift, and significant decrease in the edema in the right frontal lobe. The patient tolerated the procedure well and was recovered in the neuro ICU. Her neurologic exam remained stable. We were able to easily wean off any ICP lowering medications. This case highlights the advantages of performing the Artemis procedure with this particular workflow. With one patient transfer into the operating room, a stereotactic CT scan, diagnostic cerebral angiogram, the Artemis procedure, and intraoperative CT scan can be performed. This provides maximal efficiency of the procedure and should minimize risk to the patient. Thank you for your attention.